Dear colleagues, I am very pleased and honored to speak to you today. My name is Beate Rautenberg. I'm a senior physician here at the University Hospital in Freiburg and head of the outpatient chemo clinic, and I'm responsible for studies and drug-based chemotherapies. This is also my topic today. I would like to talk to you about new drug-based chemotherapies in the field of breast cancer and briefly also in the field of gynecological therapies. Just a second. These are my coins. First, a brief overview. I would like to talk about breast cancer, regarding breast cancer, CDK4/6 inhibitors. I will present you the right choice study, the NATALY study. And in regard of ADCs, I will present you the Destiny Breast 04, the Tropion 02, the Tropics 01 with datopotamab deruxtecan. And regarding ovarian cancer and cervical cancer, I have the Mirasol study and the Innova TV204. Let's start with the right choice study. This study was first presented 2 years ago in San Antonio, and last year there was a corresponding update. It deals with the question of whether we can also dispense with chemotherapy in advanced tumor disease, e.g. with a visceral crisis, and use CDK4/6 inhibitors instead. The right choice for the phase 2 study of the combination of ribociclib with endocrine therapy versus physician's choice combination chemotherapy in premenopausal or perimenopausal patients with HER2 negative hormone receptor positive metastatic breast cancer. What was the background, or what is the background of the study? Chemotherapy is a standard of care in advanced breast cancer with clinically aggressive disease, including visceral crisis, which requires rapid disease control. This was the opinion in 2022. As we all know, combination chemotherapy is associated with a higher overall response and longer PFS than single-agent chemotherapy, but potentially toxic treatment. Ribociclib demonstrated statistically significant PFS and OS benefits over endocrine therapy alone in 3 phase 3 clinical trials, the Mona Lisa 2, 3, and 7. No data to this time on a head-to-head comparison of CDK4/6 inhibitors and endocrine therapy versus combination chemotherapy in patients with aggressive HER2 negative hormone receptor positive disease. This was the background. Included in the study were more than 200 pre- and perimenopausal women, hormone receptor positive, HER2 negative with advanced breast cancer with symptomatic visceral metastases or rapid progression. Up to that point, that was a situation we always had to choose chemotherapy over or even combination chemotherapy because we needed a rapid response to the therapy. As you can here see, the patients were well balanced in both groups. In particular, over 60% of both groups had symptomatic visceral metastases and more than 50% had a visceral crisis, a severely ill patient population. And here you can see the primary analysis presented in San Antonio 2 years ago, a statistically significant PFS benefit for patients in the ribociclib group. Median PFS 24 months for the patient receiving ribociclib versus 12.3 months for the patients in the combination of chemotherapy group. An incredibly good result in my view, almost doubling the result. The overall response and clinical benefit rate were almost the same in both groups. In the event of a visceral crisis, we need a rapid response of therapy. Here you can see the time course until the response to the therapy, and you can see that the time to response for patients with visceral crisis was no worse in the ribociclib arm. But what about side effects? CDK4/6 causes more neutropenia. Typical chemotherapy side effects such as nausea, vomiting, or alopecia are more common in the chemotherapy arm. In summary, the Right Choice study is the first prospective study comparing a CDK4/6 inhibitor plus endocrine therapy with combination chemotherapy and shows an improved PFS in favor of ribociclib and endocrine therapy, better than combination chemotherapy in patients with aggressive tumor disease and with a high medical need for rapid response. Encouraged by these very good results, even in a difficult therapeutic situation, the idea naturally arose of using this effective substance in the adjuvant situation. As we always do, we try in the metastatic setting and then we try in the adjuvant situation, in order to improve the prognosis there too. This is why the NATALY study was initiated. The results had been presented in last year at the ASCO and in San Antonio. Here you can see the study design of the NATALY study. Included were patients with hormone receptor positive, HER2 negative, early breast cancer with anatomical stage 2A, either node negative with grade 2 and evidence of high risk, or 1 to 3 affected lymph nodes. The study was very large, with over 5,000 patients participating worldwide. 2 different arms were randomized: ribociclib plus endocrine therapy or endocrine therapy alone. The ribociclib therapy was given for a total of 3 years in addition to endocrine therapy, while endocrine therapy was given for a total of 5 years. It is important to note that a lower dose of 400 milligram was administered rather than the usual 600 milligram. The primary endpoint of the study was the IDFS. Secondary endpoint were, for example, the overall survival or distant disease-free survival. Here you can see the results that were presented in San Antonio 2023. There was an IDFS benefit of 3.1% after 3 years in favor of ribociclib. The risk of invasive disease was reduced by 25%. Now we come to the distant disease-free survival, which is much more important in my opinion. Ribociclib was shown to reduce the risk of distant metastases by 25%. The absolute DFS benefit was 2.7%. Here the OS data after median follow-up of 35.9 months, quite short. There were fewer than 4% of events in both treatment arms. These data are not mature. We need still more time. What about safety and side effects? We see much more neutropenia and more liver toxicity with ribociclib therapy. The typical side effects of ribociclib we all know, but overall the discontinuation rate was low. So in conclusion, the results from NATALY were encouraging and lead to approval by the authorities in Germany in November 2024, so that our patients in the adjuvant situation will now have another treatment option in a higher risk situation. We also have the data from the MONARCH-E study. I didn't present, but this is also a study showing a benefit in adjuvant situation with abemaciclib in patients with a high risk adjuvant situation. Now let's move on to the ADCs. This is a newer class of substance that has shown many positive results in recent years. ADCs are antibody-drug conjugates. In ADCs, a chemo molecule is bound to an antibody via a fixed linker. The moment the antibody binds to the receptor, the chemotherapy molecule is taken up intracellularly and destroys it. We all know this mechanism now. We therefore have a very specific therapy that acts directly in the tumor cells. We see a high level of effectiveness and relatively few side effects. One of the first ADCs you all know is TDM1, which you all know and which is established in the post-neoadjuvant and in the metastatic situation. Newer ADCs are trastuzumab deruxtecan, also trastuzumab-based ADC with a higher payload compared to TDM1 and with a different chemotherapy, namely a topoisomerase inhibitor. We have been using TDXD routinely for some time in the metastatic setting in patients who are HER2 positive. The Destiny Breast 03 study, for example, was the basis for this. I would now like to present the Destiny Breast 04 study. Here, trastuzumab deruxtecan was used in patients who were not HER2 positive, but HER2 low. And what means HER2 low? HER2 low is defined as an IHC score of 1+ or 2+ and CISH negative. HER2 low metastatic breast cancer is an unmet clinical need because the treatment options in later lines are very limited. Around 60% of metastatic cancers categorized as HER2 negative express HER2 low. Pathology results score are clinically interpreted as either positive or negative, as per the current paradigm seen on the left, inform whether a patient with metastatic breast cancer is eligible for currently available HER2-targeted therapies. However, approximately 50% of patients with breast cancer have tumors that express low levels of HER2, as can be seen on the right. But how is it supposed to work? A trastuzumab-based therapy for HER2 low, for example, low expression of the receptor, a situation where we know that trastuzumab doesn't work. The hypothesis is based on a so-called bystander effect. The moment the drug is taken up via the HER2 receptor and the chemotherapy is released intracellularly, cell death and cell permeability occur. The chemotherapy penetrates into the cell environment and destroys the tumor cell there. So much for the hypothesis. And here is the study design. Destiny Breast 04 is the first randomized phase 3 study evaluating TDXD in patients with HER2 low, unresectable, and or metastatic breast cancer, previously treated with 1 or 2 prior lines of chemotherapy in the metastatic setting. Patients with hormone receptor positive disease must have received greater than one or greater than one endocrine therapy. Patients were randomized 2:1 to receive either TDXD EV once every 3 weeks or treatment of physician's choice, for example, capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The primary endpoint was PFS. Here, the baseline characteristic: severely ill patients were included, including those with brain metastases. Most patients, 70%, had liver metastases and more than 90% visceral metastases in the baseline. The updated survival results were presented at ESMO 23. First presentation took place at ASCO 22 and led to standing ovations at the presentation. So results were that good. I hadn't been there in the ASCO, but I'd like to see these standing ovations for a study I never saw before, but the results are overwhelming. Here are the results of the update after 24 months. Further clear and significant improvement in PFS, 9.6 versus 4.2 months and 8.8 versus 4.2 in the total population, respectively, more than doubling. The OS also continued to be clear and statistically significant. 23.9 versus 17.5 months with a delta of 6.4 months, and same range in the all patient group. The hormone receptor negative cohort shows a 42% reduction in the death rate and 71% reduction in disease progression. With what side effects did the patient buy this good success? In particular, we see more gastrointestinal side effects and slightly more fatigue as a result of a treatment with T-DXd, a situation or side effects we know also from the metastatic setting. In summary, outcomes from the longer follow-up continue to support the use of T-DXd as a new standard of care after first-line chemotherapy in patients with HER2-low metastatic breast cancer, and is now also, fortunately, authorized for this by the authority. And it's part of our clinical routine therapy now. What about other ADCs? One substance that is certainly well known is SG, sacituzumab govitecan, a TROP2-based antibody conjugate that is now routinely used in metastatic triple-negative breast cancer. A newer substance that I will report on in a moment is datopotamab deruxtecan, or another one, SKB264, it has the name already, for example. Overall, many new ADCs are now in development and will hopefully be available to us in the near future. Let me now briefly introduce the TROPiCS-02 study. This study included patients with metastatic breast cancer who were hormone receptor positive, HER2 negative. Previously, as I just said, sacituzumab govitecan was used in TNBC, but now the study is being conducted with hormone receptor positive patients. They had to have received at least one endocrine therapy or CDK4/6, or at least 2, but no more than 4 chemotherapies for metastatic disease. Over 500 patients were enrolled. They were randomized to sacituzumab govitecan or treatment of physician's choice, vinorelbine, gemcitabine, or eribulin capecitabine. The study was presented 2022 in San Antonio and showed a statistically significant better PFS. For example, 5.5 months versus 4 months after a median follow-up of 10.2 months. The overall survival data were also statistically significant, 11.2 versus 14.4 months for SG. These good results from the last 2 studies, DESTINY-Breast04 and TROPiCS-02, have led to the very latest guidelines in Germany, the AGO guidelines from 2024. In Germany, recognizing trastuzumab deruxtecan and sacituzumab govitecan as a treatment of first choice, that is written here, if endocrine therapy is no more feasible. And now, as promised, a preview of a new ADC. I would therefore like to briefly present the result of the TROPION-Breast01, which were shown in 2023 in San Antonio. Patients with hormone receptor positive, HER2 negative, who had previously received 1 to 2 lines of chemotherapy in the metastatic setting, were included in the study. A total of over 700 patients were enrolled. Randomization was 1:1 to Dato-DXd, also a TROP2 ADC, as I just said, versus treatment of physician's choice, e.g. eribulin, vinorelbine, or gemcitabine. We see here a statistically significant better PFS with a median of 4.5 versus 6.9 months. What were the side effects? Overall, the substance is quite well tolerated compared to the usual chemotherapies. What is noticeable, however, is a rather high number of stomatitis with Dato-DXd. Fortunately, this is a side effect that we no longer see so frequently, and that we now, for example, from everolimus, but it is manageable with a good prophylaxis. The author's conclusion was as follows. Dato-DXd is a potential new treatment option for patients with endocrine-resistant, hormone receptor positive, HER2 negative breast cancer. And I will now summarize with Giuseppe Corigliano's conclusion from the ESMO 2023 here. He said, ADCs anti-TROP2 demonstrated to improve clinical outcomes, sacituzumab govitecan, datopotamab deruxtecan. T-DXd provides a higher magnitude of clinical benefit than Dato-DXd in terms of PFS and overall response. T-DXd remains a standard of care in her hormone receptor positive, HER2 low metastatic breast cancer after one line of chemotherapy. After T-DXd or in HER2 zero disease, anti-TROP2 ADCs are my first choice. So much for Corigliano's opinion, which I can only agree with. Now I would like briefly to introduce you new substance from Gynecological for cervical cancer and for ovarian cancer. First of all, for cervical carcinoma, I come to the new ADC tisotumab vedotin, consisting of a monoclonal antibody and the cytoxin monomethylauristatin, MMAE. The antibody is directed at a tissue factor that is expressed by tumor cells, which is shown here. The ANOVA TV204 was a study which led to the FDA approval, which I would like to briefly introduce here. We expect approval in Europe in the near future. I don't know, hopefully this year or in spring of this year. In this study, 102 patients with pretreated or metastatic cervical cancer were included in the study. It was a single-arm study. Tisotumab was administered 2.0 milligram per kilogram intravenous EV every 3 weeks. Therapy was given until progression or unacceptable toxicity. Here are the results. Overall response rate was 24%. Complete response 7%, partial response 17%, and stable disease 49%. A very good result for this difficult to treat group of patients. What side effects did the patients have to expect? Most adverse events were grade 1 or grade 2. There was one death due to septic shock, which in the opinion of the investigator's physician was related to the therapy. But we have seen a side effect in 26% of cases that is new to us. Side effect of oncological, as a side effect of oncological therapy, it's new, conjunctivitis. Side effects in the eye are something that we have rarely seen till now, and that we first have to learn to deal with. Here in the study, in addition to conjunctivitis and dry eyes, we also saw keratitis in some cases. 2 patients suffered grade 3 ulcerative keratitis. None of the ocular side effects were considered serious by the investigators. The ocular side effects occurred after a median of 1.5 to 2 months and lasted a median of up to 1 month until resolution. Now we come to the ovarian cancer and to mirvetuximab, a new and very effective substance that is used in ovarian cancer and which can cause ocular side effects. Here you can see the substance, an ADC with a tubulin targeting agent that binds to the folate receptor alpha. Folate receptor alpha is a membrane-bound receptor that mediates folate transport into epithelial cells. Expression is limited on normal cells, but upregulated on ovarian, endometrial, and triple-negative breast cancer cells. And here is a MIRASOL study that led to the corresponding approval. A phase 3 study in which mirvetuximab was compared with investigators' choice of chemotherapy, either paclitaxel, PLD, or topotecan, included patients had 1 versus 2 prior therapy. A total of 453 patients were enrolled. And here are the progression-free survival data by blinded independent central review. A statistically significant improvement in median PFS from 4.3 to 5.9 months, or 123 versus 146 events. And here are the OS data, also statistically significant at 16.46 versus 12.75 month median, an increase in survival of almost 4 months, which is a wonderful result in this difficult to treat population, as you all know. With regard to the side effects, I would also like to focus here on the ocular side effects, which occurred in about 56% all grades and with 14% grade 3. Here are the different ocular side effects that occurred, such as blurred vision, keratopathy, dry eye, keratitis, and so on. We are already learning to deal with the new ocular side effects, which can also be managed well through prophylaxis, e.g. through regular use of moisturizing eye drops, and in the case of eye side effects, we use steroid eye drops. I would now like come to the end and briefly summarize which new substances have shown an improvement for our patients with breast cancer, ovarian cancer, and cervical cancer. The Right Choice study has shown that the CDK4/6 inhibitor ribociclib is better than combination chemotherapy in hormone receptor positive breast cancer first-line situation, even in aggressive tumors and symptomatic disease and visceral crisis. In the post-neoadjuvant situation, the NATALY study has shown that ribociclib can significantly reduce the risk of relapse and has therefore recently been approved in Germany for this situation. In the DESTINY Breast 04, we saw clinically meaningful improvement for T-DXd versus treatment physician's choice in HER2-low metastatic breast cancer. The TROPiCS-02 showed significant better PFS and OS with sacituzumab govitecan in the metastatic setting in hormone receptor positive and HER2 negative patients who have received at least 1 prior chemotherapy. TROPION-Breast01 Dato-DXd is a potential new treatment option for patients with endocrine-resistant, hormone receptor-positive, HER2-negative breast cancer. In case of cervical cancer and ovarian cancer, in the INNOVA-TV 204, tisotumab vedotin shows encouraging results in recurrent cervical carcinoma. And the MIRASOL study showed that mirvetuximab soravtansine showed a significant improvement in PFS and OS in patients with platinum-resistant ovarian cancer. I hope you could see and agree with me that we have made incredible progress in all areas of gynecology in recent years. This gives hope to our patients. Thank you very much for your attention.